world. And we've seen in our brief concept, for those who have looked at it, that cancer, cervical cancer, kills more than 300,000 people every year. That is globally. But here in Kenya, it is estimated that at least over 3,000 women die from this disease every year. And about close to over 5,000 of them are diagnosed with the disease every year. So these are statistics according to the Kenya cervical cancer. And it's something that we need to discuss very candidly. You're here, you have the professionals are here who deal with this matter on a daily basis, and they'll be able to share with you their expertise, and you can engage them as much as you'd wish to. It is important that Kenyans know that this disease is not a joke, and I'm sure many of you know that. It's only that we have not given it the prominence that it deserves, and we need to find the solutions and see how best we can deal with this matter. At least the experts will tell us from what I've read a bit, that at least cervical cancer, if detected in the pre-stage and the vaccine HPV is used, then something can be done. They'll be telling us. I'm not an expert in that field, so they'll be able to tell us all this, and we can engage them. So it is important that as members of the guild, we'll be able to engage them and be able to ensure that this matter is brought to the surface, and we are able to take it with the seriousness it deserves. So before we proceed, even as we are eating, I think it's important that we should be able to know who is in the room. We can do some introductions, quick ones, even as we continue to have our lunch. So I think I'll start with this side. This table, I'll skip it for now. I don't know that we have another mic around here. Probably we can pass it around so that guys can introduce themselves, so that the key speakers here will be able, and our guests here can be able to know who is in the room.
Good afternoon, everyone. My name is Leon Lidigo. I'm a global health and climate journalist at Nation Media Group. Thank you.
Thank you. Good afternoon. My name is Rachel Nakitare, Elementary Broadcasting Unit.
My name is Swanya, cake member.
With my mouth full, my name is Lisa Lapsova. I'm cake council member.
My name is Aureko Aura, member of CARE. Thank you.
My name is Mashari Wamugo of TV47, CARE member.
Good afternoon. I'm Judy Kaberia, a member of CARE, and I work for Frederick Naumann Foundation for Freedom.
Hi everyone, my name is Rachel Lombaka. Currently work at the Africa Report, and I'm also a chairperson of the AJEA Award, the panel of judges, the ones who are judging the stories. And I'd like to invite you all on the 2nd and the 3rd. We'll be recognizing outstanding journalists in the industry. Thank you.
Thank you, my chair.
Good afternoon. My name is Gideon Kwachkoros. I report at Tanzania.
Good afternoon, everyone. This is Kasim Wanjiro from Tanzania, a reporter.
Good afternoon. I actually know with my name. I write for Standard and Science issues. I also have my media consulting firm called Winston Media and Research Institute.
afternoon. I'm Wambui Wamunyu. I'm a university lecturer and researcher, KEG member.
Nasalimu wote, majina naitwa Biambo Lale, member of KEG, and a media consultant and a biographer.
Hamjambo, mimi naitwa Levi Okonya, mimi ni mwalimu wa media.
Mhadhiri huyo ni Professor Levi Okonya.
Good afternoon. My name is Caroline Nadala, KEG Secretariat.
Good morning. Afternoon.
Good afternoon.
I was just checking whether to file. My name is Lena Busibori. I write for Talk Africa and also Africa Science News.
Good afternoon. My name is Ivan Kibe, Mtaani Radio.
Good afternoon. My name is Bernard Mwinzi, Managing Editor of the Nation and a member of the Guild.
Good afternoon. My name is Ken Wasuria, Programs KEG.
Habari ya mchana. Jina langu ni Hedix Obuchunju na kutoka kituo cha Pamoja FM, sauti ya Kibra. Asante.
Good afternoon. My name is Annie, Kenya Editors Guild, Member Service Coordinator.
Thank you very much. As you can see, we have a whole combination of both secular, vernacular, we can't call them vernacular, what do you call them? Vyombo vya habari mtaani, where this matter is also affecting our people, together with the mainstream media as well. So at this juncture, because I've left this table purposely, I want to invite our Chief Executive Officer at the Kenya Editors Guild, Madam Rosalia, to come over and be able to introduce the guests that she has on her table, and then she can proceed from there.
Thank you, Martin. Good afternoon. Right, happy that you were able to make it to our press club luncheon. We would like to promote credible voices. We would like to amplify the credible voices so that we are able to report better. So then I'd like to introduce the guests on this table. From that end, we have Linda Batch, Council Member, Kenya Editors Guild. Kenya Editors Guild is a professional association for media, for senior editors in Kenya. And our mission really, our role is to promote professionalism and excellence in journalism. So our members are basically gatekeepers, senior editors in the newsrooms, as well as those who have transitioned to academia and career, specifically teaching journalism in the journalism schools. And we do that because one of our key mandates is to impact the next generation of editors. So we want to also influence how they are taught in the journalism schools. Right, next we have Mildred Ngesa. Okay, she is she's a motivational speaker.
Inspirational, there's a difference.
All right, she's an inspirational speaker, and she'll be telling us her story later on in this program. Right, then I'll come this side. Professor Nelly Mugo. Right, she is our keynote speaker today. She'll be coming to talk to us later. And, she's a researcher, clinical researcher, and also working at the Kenya Medical Research Institute. Then we have our Director General, Ministry of Health, Dr. Patrick Amon. We are glad that you could join us. I'll be introducing the President of the Guild a little later on, but just a short brief about why we are doing this today. Credible Voices. It is the aim of Credible Voices is basically to amplify voices
that promote development, health issues, women empowerment, financial services for the poor, climate adaptation, research and development, among others. So those would be the credible voices that we would be looking at, but today specifically we are looking at cervical cancer. Right, and we would like to amplify these voices through convening our regular sessions. The aim is to use these voices to ensure we are getting it right in the specific issues that we are talking about. We report inaccurately. We have not spoken to the right people, or we have spoken to the people but we have not captured correctly what we should be reporting. So as part of the mandate of the Guild, it's our business to provide platforms that would then engage people in various sectors to come and talk to us about their sectors. And that's really what we are doing today. The project also engages, besides the thought leadership series, the project aims at exposing reporters and editors to research facilities that are making work with health and development outcomes, right? So we would like then to do this in the interest of promoting informed dialogue and evidence-based understanding of issues of importance, such as we would like to report accurately and contribute as journalists to better health outcomes. We would like to avoid disinformation and misinformation and demystify myths around cervical cancer and all other cancers. I say that we exist to promote professionalism and excellence in journalism. Therefore, that is what we would like to live by. So I want to say thank you very much for coming to this press club, and looking forward to learning a lot more about cancer and about the vaccine status. Right now, I'd like to take the opportunity then to welcome on board the President of Kenya Editors Guild, Zubeida Hanan.
Dr. Patrick Amo, the Acting Director for Health in the Ministry of Health. Professor Nelly Mugo, Principal Clinical Research Scientist at Center for Clinical Research. Colleagues, ladies and gentlemen, good afternoon. Good afternoon. Mko sawa? I'm happy to see you all. Karibuni sana to our press club. Our thought leadership series today focuses on cervical cancer and HPV vaccine, a topic that I hold so dear, first as a woman, a mom, and as a journalist that has interacted firsthand with women that have been affected by cervical cancer. Colleagues, as journalists, we often find ourselves in the role of preachers of the gospel, engaging in conversations and disseminating information that encourages individuals to prioritize their well-being. Through our stories and advocacy, we have the power to inspire action, promote preventive measures, and ultimately save lives. But how often do we prioritize our health? Let's do a random survey. How many of us have ever done a pap smear? I'm talking to women here. Or HPV tests. I can count the hands, like we are very few, less than 10. Yeah? That tells you something. How many of us do this test annually, or at least once every 2 years? Yeah? Now we have 3 women in the room. How many of us have taken the HPV jab? I think I'm the only one in the room. How many of us have taken our daughters for the HPV vaccine? How many? 5. 5 of us. What does that tell us? And we talk about it every day. We host people, we host experts every day. But back home, we are not doing it. This survey was not just for women. Men in the house, how many of us encourage our spouses to prioritize this? How many of you have ever told your wife or your sister or your daughter or your mom to go for a pap smear? Only one man in the room, 2. How many of you have taken your daughters for the jab? Men. Men. Only one man in the room. Yeah? What's happening? Why are we not doing it? Do we prioritize our work over our health? Or is it that we don't have time to do it? Yeah, that's food for thought. I'm reminded of a personal journey that deeply resonates with the theme for today's discussion. Last year, during the Cervical Cancer Awareness Month, a dear colleague and friend joined me in taking a proactive step towards the cervical health. We underwent HPV tests, followed by pap smears, and diligently completed the 3 doses of HPV vaccine. I also made sure to extend this protection to my daughter, ensuring she received the vaccine as well. I must confess, like many other women or moms, I initially harbored a hesitation. However, experiencing the process firsthand, witnessing the positive impact and feeling a sense of responsibility as a preacher of the gospel transformed my perspective. I can now stand before you today, not just a journalist, but also as someone who has embraced this preventive measure with pride, confidence, and an informed perspective. Recently, a colleague reached out seeking advice on whether to vaccinate her 9-year-old daughter. Without hesitation, I encouraged her to proceed, drawing from my own experience and the reassurance that there is indeed nothing to fear, but more to gain from these vaccines. I urge each one of us, my esteemed colleagues, to prioritize our health by undergoing necessary medical tests and considering vaccination, especially for our daughters. It is heartening to note that these vaccines are readily available in the government hospitals, free of charge, making them accessible to all. While my family opted for a private hospital for convenience, I emphasize that cost should never be a barrier to safeguarding our well-being. Together, let us come together and continue to preach, not just through words, but also through actions that promote health, empower communities, and contribute to a healthier, more informed society. Lest we forget, I would like to ask our experts today, is there a jab similar to the HPV vaccine for men? Because we hear they are the carriers of the virus. It's the same vaccine. Maybe you will tell us more when you come here. Do they have tests similar to the tests that we undergo as women? Like pap smear, we go for tests here and there. You'll talk about it. Asante sana. And I thank you all for your attention and look forward to an insightful and impactful discussion today. Asante sana.
Thank you so much, Madam President. Another round of applause for Madam. As you can rightly see, we have a lot of discussions on this matter to make. I'm also getting to learn. I'm a journalist of many years, but there are some things that I didn't know, and I'm getting to know them now, and it's good for me. I didn't know that I can be able to take my young girl for a vaccine. I think now you've converted me when I live here. It's one of those things I'm on my to-do list. Thank you very much. Well, as you can see from the program, we have something that is called an inside take. We normally have a journalist who is on hands-on in matters of this stories that come through them, and they're able to read those copies and be able to get to know their subject very well. So they'll be able to tell us what they have been able to deduce from the stories that their journalists on the ground have been able to they've been writing. So at this time, I'm going to call my friend Bernard Mwinzi, the managing editor of The Nation, to come here and give us the inside take on this subject. Karibu Bernard. A round of applause to Bernard.
Thank you for that very elaborate introduction. I will touch briefly on the things that I have discovered first as a reporter and second as an editor. When I was asked to speak about this matter, I felt like I needed to be here because it's something that has been very, very close to me for a very, very long time. Health and science generally are very, very close to me, and I normally grab every opportunity I have to discuss the intersection between journalism and science, and sometimes academia itself. I wanted to start by talking about what we journalists think cancer is and how we report it. But I think that has already been touched on a little bit, so I will not delve into those issues. I will discuss the issues that I experience and that we as journalists experience in the newsroom. But the first thing I need to ask is whether we understand what this means for us, what this forum is all about for us as media practitioners. I think it's important because that gives us some form of grounding so that this conversation now moves away from this room to our newsrooms and to our audiences out there. And I want you to consider this. If you walk to Nairobi Hospital and ask for an HPV vaccine treat, it will cost you around 25,000 shillings. What is the median salary of the average Kenyan? How much does the average Kenyan spend on food, clothing, and rent in a month? If you go to KNH, it's about 6,000 shillings. Between 6,000, I think, 10,000, I'm not sure, but somewhere there. And it is not always available. We talk about cervical cancer as if it's one of those many other cancers. But the fact of the matter is that this is one of the few preventable cancers that we have. We can actually stop it in its track if we are careful, deliberate, and focused about it. Which is why I was really, really surprised to learn that Gavi is launching a program in Tanzania to provide this vaccine free of charge in all public hospitals. I was told just yesterday, as I was researching for this, that Gavi had sought a partnership with the Kenyan government for the same. concerned. For a lot of us, we do not have that patience. And therefore, there is a fractured relationship between the scientists, the experts, who knows these things, and we, the journalists, who work tight deadlines, need to deliver that story immediately, and do not have the patience to research, to wait, and therefore publish something that is credible. What we have discovered, though, is that where that relationship exists, and where that relationship is nurtured, then the journalism is better. And I say that because we journalists and the scientists, the doctors, the professionals, exist for the same reasons as far as the audiences, our members of the public are concerned. Our fidelity as journalists is always to our audiences. And when we serve them right, give them the right information, address the informational needs, then we serve them right. And we are doing what our profession calls of us. The president has said that people do not want to go for tests. And I'm wondering why. Is it that they cannot afford it, or is it that we have not told them to go for it? And when I talk about we, is we as a collective, we as journalists and the government as well. Is the government running a robust communication campaign for this? If so, where is it happening? What formats? How is it propagated? Is it sending the right information to the right people in the right shapes and formats? And most importantly, even in the right postures, because that will determine the uptake of that information. I remember we had a heated conversation about, for instance, earlier designs of campaigns against HIV, and what it took to steady the ship and say this is the direction we are going to take. Is it time we as communicators realize that something is not working as far as the HPV vaccine is concerned, or as far as prevention of cervical cancer is concerned, and redesigned our approaches to communication as far as this is concerned? I think it is important, because that then will give us a solid grounding as communicators to start moving forward. People still have to pay for pap smear tests. They do. I asked around and I was told it's about between 5,000 and 10,000 shillings. And this is not covered by insurance. I don't know whether you paid out of pocket or you get to, or it was covered by your medical insurer. And then again, I don't know whether science can help us deal with this subject. Women complain that the tests are very invasive. And therefore, when we talk, and we've done quite a number of stories about this. Actually, I remember that one of the stories that we did about cervical cancer was to send a young reporter to go tested for this and then write her experience. And at first, she didn't want to do it. I could guide you to that story. But it was one of those personal experience stories that tell the pain, the shock, the dilemma, the shame itself of going for this. And then we ask ourselves, if this enlightened young journalist who has gone to school, who is a health and science reporter, does not want to go for this, or if when she goes, she feels this way, what would the average young girl feel who is targeted in these projects and programs? Who is the face, or should be the face, of the cervical cancer prevention projects? That story obviously enlightened us as journalists and editors regarding what people go through every day, and why there appears to be a disconnect between what are the desired outcomes, what people should be getting, and what eventually comes out. That perhaps could also explain the low uptake of the vaccine, or also the low uptake, the low prevalence, not prevalence, the low acquisition of pap smear tests. I asked two of my colleagues as I was preparing for this to tell me what they think about our coverage of cervical cancer and of health issues generally. And I asked them because specifically they have been awarded recently for their coverage of this matter. One of them is Angela Okech, who just, I think a week or so ago, received an award for quality, for journalism from the Quality Wellness Trust, I think. And the other one is Helen Shikanda, who has just come back from the US, where she received a global award after emerging the best journalist in the world from the American Association for Cancer Research. And I asked them, thank you very much, thank you very much. And I asked them, what do you think we are getting right as far as reporting this is concerned? Our consumers and our audiences. So we get it right in that sense. But we also get it wrong when we as journalists only report this matter sporadically. Trainings. When we go for these trainings, we say, yeah, the DG said this, this new report, this new data suggests this, and then we say that's the big story of the day. information should flow regularly and in the shape and format that is of interest to them. We rarely report prevention. I have noticed that there is a new trend in the medical fraternity towards prevention as opposed to treatment. So health now is more, and I think health policies are more preventive than curative. But we still rarely do we talk about these cancer issues in that shape and manner. And I think it's time that we became concerted in that space and we became deliberately involved in the preventive conversation as opposed to in the curative one. The why question about cancer is rarely answered. Why are so many women dying of cervical cancer? Why? Are our policies enough? Is our research right? Is the technology right? The why question is never answered in youth. And when we attempt to do it, we scandalize it. So we talk about theft,
be able to impact our people. And I'm glad you chose this subject of cervical cancer. And we're having this discussion just 2 months down the line after the celebration of the Cervical Cancer Awareness Week. It is important that we have this discussion because cervical cancer is a big public health problem globally, but more so in low-middle income countries. But within even the low-middle income countries, again, the inequities and disparities again exist. That it afflicts more the poor, the marginalized communities, and those who live in underserved communities. And that is why, if you start talking about cervical cancer, probably in one of the sub-counties, say Marsabit or Wajir or whichever county, people will information that goes to the public, that you get the correct information to the public so that together we can be able to make progress. We know in Kenya, cervical cancer is the second commonest cancer after breast cancer. But in terms of mortality, it's the leading cause of cervical deaths due to cancer. Yearly, we report, according to 2022 data, 3,900 deaths. That is about 10 women dying every day of cervical cancer. And as one of the journalists here remarked earlier when I was having lunch, if this was affecting men, probably by now we have had a permanent solution. And if you look at the direction that we have tried to take as a government, and then I'll talk to it, is a shift from curative to preventive and promotive health services. Following the enactment the Primary Health Care Act, for the first time, is anchored in law and is supposed to be fully funded by the exchequer to the tune of about 40 billion Kenya shillings as the initial investment. Why have we taken that shift? Is because the burden of non-communicable diseases, including cancers, is on the rise. You see the struggle we are going through with our health workforce. We are not going to have sufficient numbers, not in the foreseeable future, as also our population continues to rise. Indeed, the WHO says that by 2030, we'll have a shortfall of 10 million healthcare workers globally, and nearly 50% of that deficit will be in sub-Saharan Africa. And therefore, if that is the direction to go, then we have to take a futuristic view and see what will be able to serve us best. That is why we have taken that fundamental shift from curative to preventive and promotive, placing health and well-being squarely at the household level and the individual level. That the information testing or cervical cancer screening and to go for treatment. And I want to correct this. Kenya actually piloted the HPV vaccine in Kitui County in 2019, and HPV vaccine is available free of charge in all public health facilities. You don't pay a single cent. We have 3 classes of vaccines as a country. We have what we call the traditional vaccines that we procure 100%. That is like measles, BCG, rubella, tetanus, and polio. That one the government of Kenya pays religiously without default. Then we have the new and underutilized vaccines. You know, when you bring a new vaccine, you have to be able to sell that idea to the people that it's important to get this vaccine. And this is the dividend that is going to accrue out of you taking that vaccine. HPV falls in that. HPV vaccine program, which was both facility-based, that girls 10 to 14 would walk into a facility and get the vaccine, but also through outreaches and in-reaches into the community until COVID happened and disrupted the entire landscape. And all those gains that we have made were erased within that time of COVID-19. Our HPV vaccine is administered in 2 doses. The first dose, what we call a 0 dose, and the second dose after 6 months. Currently, data from the Kenya Health Information System, dose 1 we are at 28%, and dose 2 we are at 24%. Because if you look at that interval of 6 months, some people forget, some are lost follow-up, they move from one facility to the other. Through WHO, where we are a member of the 194 member states constituency, we have global targets. We agreed as a global community that cervical cancer is such a big problem, and therefore we needed to come up with targets or indicators to track towards elimination of this scourge by the year 2030. So target number 1 is that we vaccinate 90%. Disrupted by COVID, and we are able to achieve 28%. So it means we can be able to reach 90% if we work collectively together. And working with people like you who will be able to convey the correct information. And remember also when you are introducing a new vaccine, the issues of vaccine hesitancy, the misinformation, the disinformation, and more so that our guidelines indicated that only girls take the vaccine. You remember the battles we had to do with the religious communities. So getting those people on our side to be able to start making moves in terms of numbers was not easy. And this the government cannot be able to do alone. They require all actors, the same religious leaders, opinion leaders, our teachers, the journalists, everybody, political leaders, so that we can be able to champion this cause together. Goal number 2 is to be able to ensure that 70% of our women aged 25 to 49 years are screened annually. Our annual target for that, if you convert into absolute numbers, is about 1.1 million women. And as at last year, we were at 38%. So between now and 2030, if we can be able to push the 32%, we can be able to meet and probably even exceed the global target. So progress has been made. It is slow. It was disrupted by COVID-19, but all is not lost. We can be able to cover the lost ground. And the third target is, of course, that 90% of women who are screened and found to have either precancerous or cancerous lesions are treated. And again, that one, government has worked together with partners to ensure that we build the capacity of the health workforce, one, to be able to know what is precancerous, what is normal, what is precancerous, what is cancerous. We have been able to supply machines, including the 2 ways of doing this, especially, and Prof will talk about it, thermoablation, either you treat it with heat or cold. And we have been able to procure more than 1,000 thermoablation machines. Then there's a high magnification microscope called colposcope. Again, we have procured those and trained the workforce to be able to utilize them. So in view of the figures that we have and the time period required to achieve those targets, I believe if you make concerted efforts, then it is all the arsenal to be able to prevent. One, we have the vaccine. Two, you can then Prof will be able to speak to this. Change the narrative. Countries that have embraced HPV vaccination, there was a study that came out of, I think, one of the European countries. We can be able to wipe it out of the face of planet Earth. See misinformation and disinformation so that we could convey the correct information. Now that is why we are also embracing other innovations. There are self-collection kits that allows you to be able to do this in the privacy of your home, and then you can be able to dispatch it. Number two, another challenge, of course, is human capital. We have had paucity of oncologists, trained specialists in that area. And as a ministry now, our training is not just general, it is really more focused, because one, the resources are scarce, and therefore we need to be able to deploy them in the right place, in the right manner, so that we can be able again to reap maximum dividend. That is why now when doctors, and again beginning this year, we'll actually have what we call a residency program kind of approach. You apply to the Ministry of Health after we have discussed with the training institutions that this is the available positions for us as a ministry, because we have a look, we have a view of the entire ecosystem. In given numbers, it will not be that I as a promoter want to be an internist and therefore I must go for that course. No. You have to comply to what we require as a country. The other challenge of dealing with chronic conditions include financing. And again, I reflect back on the laws that were signed on the 19th of October last year. The Social Health Insurance Act of 2023 created what we call the Emergency Critical Illness and Critical Diseases and Chronic Illness Fund. Again, which is supposed to be fully funded by the Exchequer to the tune of about 20 billion Kenya shillings as seed capital. Many a times, the range of tests that you are supposed to go through, the number of consultations you are going to undertake with a specialist, many a times your cover runs out even before the actual treatment begins. And many a times Kenyans start treatment, either chemotherapy or radiotherapy, priority that the government is giving to this public health burden. And we'll continue to work together with all partners to be able to support our cause. At a global level, we are working with the International Atomic Energy Agency, which has gladly offered to give us two linear accelerator to talk about it. The one that generates the beams that are used to burst the cancer cells. And we are going to place one of those equipment in Nakuru and the other one in KNH. Any cancer center that we start, we are supposed to have two machines at any given time, so that if there's a downtime, the health services are not disrupted because the next machine quickly kicks in. As I close, I want to congratulate you on this initiative and request you if you can be able to have it either on a monthly or quarterly basis. And that we may not be able to communicate to the public in a manner that they can be able to understand. Because when I go to talk there, I talk as a doctor, and many people will not be able to understand what I'm saying. But when I talk to you, you have your way of synthesizing that information, making it more palatable to the ordinary mwananchi to be able to uptake. So I request that you give us the invite in good time. We'll be able to send representatives at the highest level so that we can be able to tell you what we're doing at the ministry for the people of Kenya. And we can be able to work together in this, not only locally, but also regionally, such that when we also have our events outside, we go there as a team. That this team of journalists are the ones who are working with the Ministry of Health, rather than a foreigner. With those few remarks, I want to thank you most sincerely, and I wish you fruitful discussion. Madam President, I beg for your indulgence. I have to go to OP to talk to my brother Davji so that Asante.
Thank you very much for a DG. Round of applause for a DG. Thank you very much.
Thank you very much, Doc. You should have taken a photo with this, or you do it some other time.
No, we will take it now before. DG is a very busy man.
Yeah.
I doubt whether you will find him very easily.
That's not who he is. He's
asked if you know the DG has made very important issues in this presentation, and maybe we'll take one or two questions on this particular subject of the matter, so that so that it's easier for guys to be able to know. A quick one, just even as Leon, you're lifting your hand, I got to know, and I don't know whether Bernard has left, because his question, one of the questions he raised about issue of Gavi rolling out something in TZ. We didn't know that this HPV is free of charge in our medical health facilities, but none of us knows about this. So I think we need to have at the ministry deliberate communication strategy, the same one we used during the COVID-19, so that we are able to roll these things up.
outside Nahumicha's office for 1.5 hours just with questions that Kenyans needed answers to. How are we going to work with the Ministry of Health that is not talking to journalists, that treats journalists like enemies? I think someone told them their job is to safeguard their bosses from answering questions. Thank you.
Another quick one, yes? Bear in mind that the DG needs to dive out to a very important meeting.
My name is Wambui Wamunyo, and because I'm a researcher, I have an interest in research. I want to make 2 proposals to the DG. One is about the provision of statistics as ways to communicate about the work that you're doing. And if it is available data already, are there portals or places that this information can be found, not just about cervical cancer, but more broadly about other health issues? The second is actually a proposal concerning our health coverage. A lot of cancers are discovered at stage 3 and 4, to my understanding. And if preventive care can enable that cancers to be found at stage 1 or 2, where I think they have better chance of being treated, is it possible that even SHIF or NHIF, these health insurances, the public ones, that if somebody is not using health insurance for, you had an accident, you are admitted, but in the whole year you spent money, that you can be given a provision to even get tested for certain things or to get full medical checkup, so that it is at getting preventive care and capturing these things. So that is my proposal. Thank you.
Last one.
Sorry, I've just grabbed the microphone because I really want to have a burning question. My name is Odhiambo Lale, I'm the consultant. My question is this, but before the question, a comment. Bwana DG, you worked with so much zeal, especially the time when COVID was here, and you saved our lives. And if anything, you need an award. If I was the President of the Republic of Kenya, you'd have gotten an award. Now the question is this. Cancer came after COVID and AIDS, but it came and overtook all of them. And it became no longer just a health issue, it became a national issue, security issue and everything. And within 2 years, by the time it was disappearing, wherever it went, everybody knew what COVID is, what causes it and all. Why is it that with cancer, there's still especially the issue of where we talked about men, why men? We seem like we don't know and we just choose not to know. And we are also fearing even to take our spouse or even our daughters there. Why is there that this thing has not is still being alien to us, especially as men now? Thank you.
Yeah, I think the DG can take those ones because he needs to divert.
Because you won't be there when I'm speaking.
Okay, I'll take another second now.
Okay.
Yeah, so that I don't lose my thought process. I will not answer Leon's first part of the question because my boss has dealt with that matter on Tuesday during the press brief at KICC. And as a bureaucrat, once your boss has spoken, a position has been taken, I stand with that position. Regarding your second part of the question, and I have conversation, yes, during COVID it worked very, very well. Because we had Martin, we had other people from the media, and information flow was seamless. But apparently after COVID, then we got again disjointed. I am usually available to be able to provide information, but that notwithstanding, I cannot be able to provide information for everything in the ministry. So what we need to do, if you can be able to have a discussion, we can be able to have a structured way of engagement, whether we can be able to allocate even just 2 hours in a week, where we can be able to engage with you and share information, respond to your questions. That can be a proposal that can be able to come from this Credible Voices meeting. Wambui, yes, your suggestion of us using statistics, yes, there's even a portal of the ministry. If you go to our website, we even have a school at the ministry called MOH Virtual Academy, where you can even be able to undertake a training. You'll get a certificate that is credible. Yes, so we need to work together so that the challenge I have is that we do a lot, but it's only known to ourselves. So we need to be able to have a system of how we can be able to convey this information to the public. Yes, Odhiambo, about stigma, fear, misinformation, whole of society approach, everybody has a role to be able to play in this. Men, we must be able to support our women to be able to go for screening. We must feel comfortable enough that I can be able to take my teenage daughter to the clinic for HPV vaccination. And if we do it together as one whole society is how we are going to make a difference. And also by conveying the correct information. Yes, now let me just stand here and respond all.
Have you finished with what everything?
Yes, I finished that one, that section. Yes.
Thank you, Bwana DG. My fear is that you will leave before I speak. So may I just ask, as a cancer survivor and warrior, so we say warrior when you're still in active treatment, and I am. I want to implore you on two issues. Point number one, because of the strike, as we strike, as you speak, cancer warriors are falling by the hundreds, and we know that. Because as you know very well, Daktari, when you start active treatment, you can't stop. You are not supposed to stop chemo in the middle. You are not supposed to stop radio in the middle. You have to restart. I want to urge you, and I know you have done it because of the person that you are, to visit cancer centers to see the turmoil, the heartbreak, the desperation. The private hospitals are trying to manage. The public hospitals are at zero. It is a plea and it is a cry. Point number two, Bwana DG, as all, the plea that I had in my heart was, how can this government not make cancer a national pandemic, a national disaster? Bwana DG, I did my mastectomy in a very small hospital that had 12 beds. I asked them at the end of my session, there are 4 days, how many mastectomies do you do in a week? They told me, Mildred, in a week we do about 12, and hysterectomies we can handle about 7 in a small hospital of 12 beds. My media colleagues, journalists, do the maths if we are talking Kenyatta or the hospitals in the community areas. So my question to you, Bwana DG, like Olale, my senior, has said, we have seen the zeal in how you work. Cancer is a pandemic and you know it. People are falling by the throbs. We don't even know the exact numbers. Could this be that the time of your tenure that we will make cancer a national disaster, so that the emergency, the criticalness, the urgency of the cancer beast can be addressed as it should? Thank you, Bwana DG.
Any other, a quick one?
Yeah.
A very quick one.
My name is Marie Yambo from KBC. So I heard you speak and you talked about the self-testing kits, because again, I think one of the speakers talked about, going for pap smear being a barrier for a lot of women. So how available is it? Does the public know about it? Because I happen to know about it from another, engaging with other people. And is it for free? The other thing, we are targeting cervical cancer, which is affecting women. But what are we doing to sensitize men? Because I'm not so sure about the science of it, but it is sexually transmitted. So how much is being done to also sensitize the men, even as we target the women? In as far as preventive is concerned, I also understand nutrition is a very big part of it. How much is being done? As far as nutrition is concerned, even if you're providing the means of early testing and all that.
Thank you. A last one. Let me go that side. It's silly.
Thank you, Martin. My name is Maslin Nahala, also a cancer survivor. My response is almost similar to my sister Mildred. When I look at the figure, 10 women dying per day, and I'm just trying to picture it, 10 women per day, it is like all the women in this room, within a week, they're not there. Within a week, that is what is translated. Statistics, when you put a person to it. So my question is, I also have a similar question. Is it possible to now declare breast, cervical, and prostate national disaster? These three cancers, I think, from my experience interacting, these are the major ones. And then my next question is, similar, related to that question, what is the public communication that you're currently employing? I'm imagining the rural areas. How are you reaching the schools? The age of the girls that are supposed to do the HPV test vaccine. Is there a very, very clear way to reach them that maybe all the primary school can be reached so that they are caught early? Thank you very much.
Thank you. I'm going to read the last one from our legal team together with the here.
Thank you, ma'am. Dr. Apart from being an editor, my other life I'm also a lawyer. And I've got clients who are suing the doctors for one thing, negligence, especially in diagnosis, what we call misdiagnosis. When they go to India, they are told, had you come earlier or had in Kenya been done the correct diagnosis, we would have saved you. And now when they come back, they want them to sue many of you. Could you please address this issue, the misdiagnosis? Is that a problem in Kenya? Thank you.
How quickly to Pista?
Yeah, thank you very much. Somebody has asked a question about the shortage of cancer treatment. I think chemo treatment. I don't know whether that was answered. If you could please address that issue, because I think sometime last year there were cancer patients who are complaining about the shortage of that treatment. But I also want to throw in the issue of the cancer of men, prostate cancer. Do we know the numbers? Thank you.
I think you can take those on PG.
Okay, thank you. From my sister here, the warrior, of course, and I've spoken to this earlier, that industry of disharmony disproportionately affects women, children, the elderly, those with disability, and marginalized communities. During this strike, of course, the disruption of the services has negatively affected service delivery. And with our brothers from NBDU, we had agreed on 18 out of the 19 grievances raised. We had developed a return to work formula initialized by all parties, and we were ready the following day, Monday, to be able to sign the return to work formula. Unfortunately, that did not happen. So my appeal to the union is that Kenyans are suffering. Let us sign the return to work formula and address the one remaining issue. We should not throw the baby with the bathwater. It's an opportunity for us to be able to make a difference. Number two, declaring a cancer a national disaster. It can be a pronouncement, but what happens thereafter? Yes, somebody could come and say it's a national disaster. But will that trigger the resources to be able to flow in tandem to be able to address the pandemic? Will that trigger all actors to be able to act collectively along a common cause? Those are the kind of questions we need to ask ourselves. We know the burden of cancer is on the rise, and by 2030, from Kenya Health Information Systems, we expect non-communicable diseases led by cancers, hypertension or cardiovascular diseases, and diabetes to overtake communicable diseases. And therefore, the problem will even be bigger. But that's a discussion that we can be able to initiate at the ministry level, working together with other actors, so that we can be able to give a good technical advisory. Cancer being a disaster. For HPV vaccination initially was based on community approach. But then we realized that if we go to the community approach, what will happen at school level? So we say let's do a multi-prong through the community and also through the schools, because also there are some girls 10 to 14 who don't go to school for one reason or the other. So they should not be able to lose out on this intervention just because they don't go to school. So community engagement is very, very important, and we believe that going forward, if you can be able to strengthen the community health promoters, then there will be a good channel for communication to the community members. Misdiagnosis, yes, definitely, there are cases, and most of these usually are handled by the regulatory authority, and that is why we are saying it is our role to be able to capacity build the healthcare workers so that they have enough skills and the requisite expertise to be able to make correct judgment. So that even, of course, even in the developed world, we are still misdiagnosis, but you minimize that to the least possible numbers by giving the healthcare workers the right information and the right tools so that they can be able to make their correct decision. Topista also emphasized on the disrupted services. Again, we are alive to that, and I can assure you the government is committed to addressing this matter once and for all. And one thing that we have agreed, whether the strike ends today or tomorrow, is that we will not go back to our default settings without putting a system into place to be able to address the perennial issues that keep on appearing in the grievances. In fact, we are going to propose a radical departure as to how to address these things. But not only address it from the demand side, but also from the supply side in terms of the quality of the healthcare workers that we are training, that they must meet. Our way to aggregate our requirements for chemotherapeutic agents for the whole country, and procurement is done centrally from KEMSA for economies of scale, so that we can be able to negotiate big discounted prices. But going forward as a country, we are also focusing on local manufacturing of health products and technologies. So long as you don't manufacture, and we saw during COVID-19 pandemic, you cannot be able to significantly reduce the cost of healthcare if you rely on other jurisdictions to source your health products and technologies. There was one exception. Now she's on phone. Okay. She is lost.
Thank you very much. I heard my sister Mildred say that from a cancer is very good, but it starts from. I went for a pap smear, and it is painful. Number one, Aga Khan, they send in tons. And I remember I got very cross and I told them to get out of the room, and I decided to wait for the doctor, who came and did it in a span of 4 minutes. The other thing is my cousin, we buried her last month. She died from cervical cancer, and she was admitted at Jomo Referral Hospital. Yes, yeah, that's where she was. And I remember I stood by her, and the main problem is this test she had to go through before she starts her chemotherapy. And the problem we had was the long wait. We would be there at 7 o'clock, but she would be to start her chemotherapy maybe at 3 o'clock. She was in so much pain. I noticed that even okay, you could see there are many beds, but there are too many people. Is there anything that can be done in terms of adding more beds or something like that? About Aga Khan, as you said, capacity building, the people that you're training is very important, because from that day, that was about 2 years ago, I've not gone back for a pap smear.
Thanks for that. I think I told you about the investment that we have made in the public space, from Nakuru to Coast Regional Cancer Center to Garissa. And I told you about other upcoming. I forgot to tell you about it in Kimathi in Nyeri, the one in Kisii that is supported by the Hungarian government. We will still need to invest in the cancer space in terms of equipment, infrastructure, and human capital, because the burden is huge. And that is a challenge KUTRH has faced because of the numbers, and because it has modern equipment, many patients tend to go there. And that is why, with the support of International Atomic Energy Agency, we want to put a second LINAC at Kenyatta, and we'll also be able to have a second LINAC at Nakuru. And therefore, by establishing more centers, then we believe that we can be able to improve on the coverage. That investment cannot be made by the government only. And I'm glad the private sector is also seized of this matter. Now we have a PET scan. We have 3 PET scans in this country. Now we have a PET scan at Akan, that was the initial one. We have one at KUTRH. Nairobi West has also put up a PET scan. We have, I think, now actually we have 4, because HCG Hospital in Westlands also has a PET scan. And Ruai Family Hospital is building a cancer center. They have already ordered for a PET scan. But even us in the public space, I think it's a high time now we started investing in PET scans for Nakuru Coast, and from inception, Kisii and Bida and Kimathi in Nyeri, that should be part of the package. Steps made, small steps that we are going to make, despite the tight fiscal space, but showing that commitment. In fact, I can tell you without fear of contradiction that in the next 5, 7, 8 years, Nairobi is going to be the hub, the medical tourism hub for treatment of all sorts of cancers. Do you know currently we get patients from as far as Cameroon, we get people from Guinea, we get people from DR Congo. That is the way to go, so that we become a region or a center that is so well established that we can be able to accrue dividends from the investments that we have made, both in the public and private sector. That's only possible if we are together. And finally, for those of us who have the power to amplify these voices, like you, can we agree today going forward that we are going to make differences in our places of work, in our communities, in the people we interact with? Asanteni.
Thank you very much, DJ. A round of applause for DJ. Thank you so much. I think we have learned so much. The time is few. We have very little time for this subject, and I think we'll make more time to be able to amplify this matter. A quick photo here with the Guild team and these are key speakers, and then even the cancer warrior can come here.
You see the way men are shining away.
Martin, may I just quickly encourage Bwana DG that it was in 1987 that the leadership of this country mentioned the word sex as we battled the spread of AIDS. Before then, there was stigma. And when that was mentioned, it picked up, and of course now we actually dared it. Uganda was long doing it. So now, Bwana DG, I'm still encouraging you that the leadership must mouth the word pandemic. It will help.
Thank you. You've been thoroughly heard.
Men are the boy child is very shy.
They don't want to be up.
Come to this. Why are men so shy? Give us a scientific explanation.
Prof is the one who has done those biobehavioral things. We'll be able to tell us where we don't work.
Thank you. May take your seats.
Bado hatujamaliza. Please let's settle down. Hatutaki kushikwa na traffic ya Nairobi. Linda, let's settle down. Ndio tuendelee. And I'm happy that Daktari spoke about how invasive this test is, pap smear. And I think that's why most women shy away. But when I went to Lancet, we were given that HPV test kit. And I was like, yeah, kudos to technology. Because I was told you can do your test, you can take your sample from anywhere. Kwa choo, kwa gari, kwa bafu, kwa wapi. You just take the sample and then you take it to the lab. And I hope these kits will be available in our public hospitals. Because itasaidia sana to boost the number of women that go for the test. So allow me now to invite Prof. Nelly to speak to us. Being a scientist, please, Prof, speak to us in a language that we can understand. I remember when we went for the Africa Climate Summit, tunaanza kusikia carbon credit, what, and we're like, how are we supposed to tell this story if we don't even know what carbon credit is? So please do our men a favor. Most of them are like, we don't know what these things you're talking about are. Please help me invite Prof to speak to us. Thank you for making time for us.
Thank you very much. Good afternoon.
Good afternoon.
I hope I can still maintain your attention on the later part of a Friday afternoon. When I was called by the editor's guide by Rosario and I was told it was cervical cancer, I said I'll drop what I'm doing because the issue of advocacy the 1940s had the same number of women dying from cervical cancer as we do today. So what changed is that they had national programs. So what our president told us, she's able to go to Lancet and do But when it's a national program, in countries where there are national programs, we're constantly looking at our data and saying how many of our age-eligible women are screened, where are the gaps, who are the women not getting tested, what category, how do we reach them? That's the missing thing. So in Kenya we have a national program, but it's not resourced. So if you go to the Division of Family Health, we'll tell you, we do something called visual inspection with acetic acid. And this is Professor Mothos, Dr. Moth talked about, we have the tools. And I'll just quickly try and go through the tools. I'm trying to build through this. But we have the tools for prevention. One, we now have a highly effective and safe vaccine. And I know there's a lot of misinformation on the vaccine. I think as journalists, you've heard the stories, right? I don't want to underline them because I was told in a little bit of my communication, if you repeat it, other people repeat it, and people will not know if it was true because it sounds saucy. So a lot of misinformation. But we have millions and millions of people vaccinated. In my house, every boy, every girl has been vaccinated. In my clinical trial site, everybody's vaccinated, and their families are vaccinated because we're strong believers, and because we know this vaccine is safe. We've been doing research on this vaccine from 2014. So I can tell you without a doubt that the information on safety is robust. It's a vaccine-like particle. It's not a live vaccine. So what people get is pain on the jab, a lot of, a bit more pain than usual, a bit of fever for some of them, and then it's gone. They don't get the disease because it's a virus-like particle. It's a synthetic vaccine. Highly effective, 98% effective, more effective than measles and polio and all other vaccines, right? And now we have data from research done here in Kenya by chemistry scientists that one dose is enough. The national program, the national immunization program, people are still evaluating the data to shift to one dose. But we have lots of countries, Nigeria, Bangladesh, Ireland, the UK, Australia, have also moved to the one-dose schedule. And the World Health Organization recommended the one-dose schedule. I'm actually very proud of that data because we did that work here as chemistry scientists to prove that one dose is as good as the multiple dose schedules. So it's a vaccine that's safe and works really, really well. There's a little clip I like to show and have a slide, and it says, we have a vaccine for cancer. Why are you not using it? And I think that's a question we need to ask ourselves, ask our families. When you go home, my dear fellow man, please ask yourselves, why isn't your daughter protected? Why isn't she vaccinated? The vaccine can also be given to boys. It's safe because men also get oropharyngeal cancer, head and neck cancers, 45% from HPV infection. Most anal cancers are in men more than women, also from human papillomavirus. Now, penile cancer, 70% from human papillomavirus. But penile cancer is not common, so you don't hear about it. So what's this problem with cervical cancer? And we talked about stigma. Now, how many people can comfortably talk about the vagina in their homes? Can that be discussed?
No. It's a taboo.
It's a taboo. How do you tell your mother to get screened and where and on what? It becomes a bit of a challenge, or your older sister. So those are some of the challenges in awareness and in messaging. In what we call, when we do research, we often have what we call community advisory groups, yeah? So when we're doing the research, before we start, we go to the community of representation. We tell them the work we want to do. They give us feedback, what they think about it. We tell them how we'll do it, and we meet regularly. And I remember one of our community advisory group members, she's a nurse, and she was at pain when she explained to us her mother's story with cervical cancer. And she said she went home and she realized that her mother had moved out of her father's bedroom, and she thought it was a little peculiar, but they didn't discuss it. But the next time she came, it sort of nagged her. So she went to her mother's bedroom and she opened the bedsheet. It was a flood of blood with blood clots, because that's what cervical cancer does. And one of the reasons most people don't talk about it is because the early signs is vaginal foul-smelling discharge, because cancer becomes a wound. And it's a wound which begins to rot because the cells are growing really, really fast, and the blood supply is not enough, and they shed off, and it smells. Now, how does a 60, 45-year-old woman, who pays their bills when they're sick, who do they call on? Their children. Those children, are they often daughters or boys? Who has the money? Boys. How do you tell your son you have a discharge? You smell. So our people come late, yeah? When it's no longer deniable. By the time they are bleeding that heavily to soak their beds, it's really, really late. When I was in training in Kenyatta, we used to have a ward called Ward 6, then 1D, a gynae acute room. And we have two rooms full of women with cervical cancer. It was a really smelly room. But there was so much pain and suffering in that space. And we reached a point in the hospital where we wouldn't admit these women. Go to Bagathi, elsewhere, to get transfusion before they come for radiotherapy. I know you feel that pain. And when you're a provider that is telling a family, coming with somebody that sick, that you're not going to admit them, and they're crying in pain, you're in pain too. But that's what happens, and that's why we need to prevent this cancer with a sense of urgency. So my plea to journalists, this vaccine needs to be taken up. Our uptake has been low. Initially, there was a global shortage, and you know, similar to COVID, guess who got vaccinated first? Who's making the vaccine?
The men.
No, it's the West.
Oh, the West.
Yeah, that's why Scotland this year, what Dr. Amok talked about, was able to show that all the girls they vaccinated in 2017, millions of them, none of them. Australia is towards elimination, which is less than 4 per 100,000. Australia was an early adopter. So countries are moving to very low number of cases. Now I ask myself, what will happen when the Western countries no longer see this disease? Who manufactures these new tests, the drugs, the equipment? Are we doing it?
No.
Where's the innovation from?
The West.
I know you've heard of neglected tropical diseases, right? Yes. So my fear is that this may very soon join the category of what? Because now in countries where they're seeing very few cases, they're saying they want to change how they screen. Because you're not likely to pick up disease. They're getting rid of it. So how you screen is different when it's a rare disease. But it's not a rare disease for us. So if we don't pave our way forward and don't catch up, we will lose mothers. There's some other aspect which is not well discussed. And I always ask this question: what is the cost of the death of a 45-year-old woman? She's not going to get the funeral of a high-ranking general, bless his soul, for his work. She's buried quietly. True or false? Who's left crying? What happens to those children? Teenage pregnancy, am I right? School dropout. What happens to the man? Can he work properly? So there's society disruption. So I always say, when the government or we as a society don't invest in protecting women, we're harming ourselves without the foresight of the value of keeping that age group of women who died from cervical cancer alive. I remember once when we were talking HIV with Treasury, one of the Treasury officers said, you know these Oye stories? Oh yeah, women are dying, oh yeah, this disease is coming. There's Oye everywhere to them, oh yeah, people are dying on the road. We need to go back to them and tell them, when we save this life, what do we get back? What's the gain to the economy? What do we save going forward? So that's vaccine. I hope I've convinced you. It's a highly safe and effective vaccine. We have population level data to show it. I have done this research for several years. I'm following a cohort of young people we vaccinated 9 years ago. None of them are getting infection. So for me, it's hands-on, it's real. Both safety and effectiveness. And I've told you 1 dose is enough. For girls between ages 9 and 20, they can get 1 dose. That's a trial I personally am doing. And we're now going to our year 5 of follow-up in that cohort. And our data repeatedly shows us the same high level of protection. For the older, we don't know, and for boys, we don't have that data. Why are we concentrating on vaccinating women? Because the highest burden is cervical cancer. So there's something else called herd protection. Herd protection means if we vaccinate girls, then boys also get protected. So overpopulations where they have high coverage, over 50% coverage, then the effects start showing up in the boys too. So our priority where resources are limited is to vaccinate girls. When there are adequate resources, then we do what we call gender neutral vaccination, and we want to vaccinate boys. So when I had access, my boys got vaccinated. Okay, screening. We talked about how painful and uncomfortable pap smears is. I agree. But it needs to be done because the cancer hurts so much more. I'm sorry. Please stand up. Please get screened. But I want to tell you the screening schedule need not be annual. This is a cancer that takes a long time. From the time of HPV infection, there are lots and lots of HPV types, over 100. Then we have about 14 high risk which cause cancer. Then about 5 that cause, 7 that cause 90% of the cervical cancers. It takes up to 10 years from that time to invasive cancer. So we have this wide window of opportunity to screen a woman and protect her. The pre-cancer lesions detected, we treat them in health centers. Well, Dr. Moth talked about thermoablation. I didn't screen up. But the equipment for thermoablation is something really small with a flat thing at the top, and then we train the nurses to use them. And it does 20 seconds on the lesion, and you're off the bed, you're treated. If we can pick it in, pre-cancer. The visual inspection tool, you use vinegar. Tunajua vinegar, but it has to be the right concentration, 5%. When you apply vinegar on the cervix and the early changes, we can see them. So you can see that and you can zap, and she's good to go. But we don't have a program. And this visual inspection is difficult for training, and the nurses, and the time hasn't really been there. And you say pap smears are difficult. A pap smear needs a lab. You take the sample, it goes to the lab, you come back for results. So lots to follow up, cost, return visits, all of it. So now comes the HPV test, and that's a self-sampling that you experience. So the self-sampling is that you can take the swab, it's a dry swab, and the woman self-inserts herself. And she does this, puts it back, drops it off to the lab. Much nicer, right? And it's as good as physician collected. The data is robust. And HPV testing is more sensitive than pap smear, performs better. It's just that we'll need to do something else amongst a select few who have HPV and then treat them. So we agree we have tools, right? And then if you have early cancer, if we do a hysterectomy, you're cured. That's it, done deal. We can do hysterectomies in Mandela, Sindio. Everywhere we can do hysterectomies. So we have all the tools we need to protect. I hope I tried not to talk colloquial.
You're good. We are following.
I hope it's making sense. Yeah, and I'm trying to see what other points I might have talked about. I said you can vaccinate boys. Boys get anal cancer, warts, and all other types of things. I think I've come across like 2 cases of penile cancer. It's horrible. You don't want it. And of course there are warts, sir. I tell people warts are just not nice. Has anybody seen genital warts? They look like cauliflower. Makes peeing very hard for the men, but they're treatable. But the vaccine also prevents warts, highly effective. And then we have oropharyngeal cancers, which are also preventable. So I think I've tried to go through all of this, except I was very ill-mannered. I didn't thank you at the beginning, and I appreciate all of you. And the President Zubeda, right? And our President, Amungo. CEO, sorry, apologies. Yes. And my friend, I want to get the right name that you prefer to be used, Mildred. You told us it's not activist. I know you're a survivor warrior, but there's another name. Inspirational speaker. And you inspired, I think, when you talked to us. So I can't say it enough. I used to harass women in my mother's sitting room, asking them if they were screened, constantly. 3 years ago, a very close relative of mine had been calling me with backache, and I wasn't paying attention, I was busy. And when she turned up, she had stage 2 cervical cancer. That treatment cost $250,000. NIH used to cover it, NHIF, right? Currently, I have somebody in my house with breast cancer. A round of chemo is $150,000. She will need 3 cycles every 3 weeks. Where does that money come from? So everything we can do for prevention. And it breaks my heart that also for breast cancer, the awareness that if you have a lump, get worried, is still not there. That people don't know where their cervix is. And that we're not screening, that we don't have coverage, and that we're not vaccinated. So please start with your homes. Can I ask you, all of you? Please harass people in your homes. Follow them up, hound them, make sure your wives are screened. You will not forgive yourselves. Talk to your sisters and get your girls vaccinated in your households. So thank you very much.
Asante sana, Prof. Do we have questions? Najua wengi tunauliza how is cervical cancer, throat cancer, related anal cancer. You know, times have changed. Watu wanajaribu mbinu zingine, you know, kuliko kando na zile ambazo tumezizoea. Yeah, and our kids have become very sexually active. You see a 9-year-old, 8-year-old, already wanajua. Naambia mama, wewe unamniambia nini about sex? I already know these things, you know? So and that's why I told myself, Prof, I don't want a day to come, God forbid, niseme I wish I did it that time. Because we have the information, but what are we doing with this information? Are we helping our kids? Ama siku moja tutakuja kusema majuto ni mjukuu. Mtoto wako ndiye yule ameshiriki mambo, then you say I wish I knew. So we have questions. Amato, please help us. Prof, maybe you can come here and then respond to some of these questions.
Start.
Yes, my question is, this disease is given to women by men. How come it does not affect men? That's one question. And second, you talked of 98% effectiveness. Is that what WHO is also saying, or somehow exaggerated? Then another one. All these forms of cancer, which one is the deadliest, the most lethal, and the most prevalent in Kenya?
Thank you. Just take note about 2 more. It seems this is the time for the boy child. You want to swam away with the light touch. You know, Kenyans don't like to laugh. I think I'll pay you some money, like Churchill, and then you check. Yeah, I don't know, there's a question of observation. There's this information overload. Like since you've been here, you've given us a lot of information. We've learned so much. Hopefully when we go out, we'll be able to implement 1 or 2 things. But then my concern is this. In this information overload, of course, there's a lot of fake news, this and that and that. Nutrition, I didn't hear that aspect of nutrition. Let me help me with that part. Because there's too much information. Don't eat this, don't eat that. Do this, do that, you know. So other than the vaccine and all those other things they say, where does nutrition come in? And especially, you know, some of us love out there. And some people will tell you, please, 3/4 of the plate, a third of the plate should be ugali only, or protein, yeah, nutrition. Let us know how nutrition can also help us.
Thank you. Last one.
And exercise, of course.
Thank you, Dr. Nelly. My first question has to do with what I learned in India they call medical touch.